Good afternoon, everybody. My name is Wendy Nelson. I'm at the Office of Behavioral and Social Sciences Research here at the National Institute of Health. People are, if you're hearing beeping in the background, I'm not quite sure how to get rid of it. I think many people are joining us. So I'm welcoming you today to the Smart and Connected Health webinar. I'm very excited that you're here and able to join us for this. This is NSF solicitation number NSF 13543, and at NIH you can find it under NOT OD 13041. With this, I'm going to turn it to one of my colleagues, Brad Hesse from the National Cancer Institute, to start us off. Thanks, Brad.
Wonderful, and welcome everyone. We're very excited to be able to talk about this opportunity right now. This is something that's been in the making for a little while. And what we want to talk to you about is exactly what at NIH we think we can get out of this partnership, and then NSF is going to talk a little bit about what they expect out of this partnership, and then we'll go through the routine of what it means to compete for this. To give you some background, we're going to go to the next slide. Do I just click on something? Slide's going to come through any minute now, I can tell. There we go. I go back about 2 years ago, and our director at the National Institutes of Health, Dr. Francis Collins, was given a keynote on a Sunday to the American Medical Informatics Association. It was a very interesting and impactful keynote. And part of what he was saying is he was talking about how our technology on the gene sequencing side is actually exceeding Moore's Law in terms of speeding up how quickly we can sequence genes. And he said, that's exciting. But we're now generating a lot of data, and we need to use that data. That's the next step. We need to use that data within healthcare, and we need to use it for discovery. And the only way we're going to do that, the only way we're going to succeed, he said, is if we work very closely together. Those of us who are skilled in the area, well-versed in the area of biological sciences and health system sciences, and those who are skilled in computational sciences and computer system sciences. So that's the reason why we've reached across a bit of a channel to the National Science Foundation to say, you know what, we need to work together. Let's go to the next slide. Around the same time that all of this is happening, and many of you probably already know about these two reports that came out delivered to the President of the United States. This is from the President's Council of Advisors on Science and Technology. The first one was delivered on December 10th of 2010 and had to do with our investment in health information technology. So many of you on this conference call understand that we have a big investment since 2009 in the Health Information Technology for Economic and Clinical Health Act, it's Title 13 of the American Recovery and Reinvestment Act of 2009, and that's been pushing out a lot of connectivity in the area of electronic health records. So that particular report said this is important. We need to realize the potential, in fact, of these electronic health records, and it's not going to happen solely from the health sciences. We're going to need help from computational and network sciences to make that happen. And the purposes for it, of course, is to improve quality of care, to engage patients, and give patients the same kind of support we can give, gosh, and even driving their cars with a GPS. To create an infrastructure for clinical studies that's superior to none. To improve population-based knowledge, to develop new tools for medicine, and to increase administrative efficiency. We have to roll back the costs that we're experiencing in healthcare. That's another crisis. That was on December 10. Exactly 1 week later, a parallel report came out, and we'll go to, yeah, that's right. And this was really themed around designing a digital future. And what was interesting about that, it was a set of recommendations for federally funding the area of networking and information technology across several parts of the economy. And the very first recommendation, the very first part of the economy, not to our surprise, had to do with health. And within it was the mandate that the National Institutes of Health and other components of the Department of Health and Human Services, in fact, needs to work with the National Science Foundation, with other agencies. Okay, so there was this edict that, in fact, we need to work across organizations, that this is no longer the kind of problem that we can solve from one side of the fence or the other, and this becomes a national set of priorities. We've had two other subsequent reports. The most recent missive, I think, on that was just about 2 days old, that reinforced the importance of setting this as a priority. Let's, do we need to do anything with raised hands? Questions on the screen?
All right, good.
So
We're good?
we're good. Okay, very good. All right. I want to go to what that report talked about when it was discussing, in fact, what we can do in the area of health with network and information technology. And it said that in parallel to what's happening within healthcare systems, we also need to understand how to create comprehensive, lifelong, multi-source health records. And very much like we've done perhaps in the financial sector and some other sectors, though not as much in travel if you try to travel American Airlines recently, we need to be able to solve the problem of interoperability and changing from different sources and even from sensors now that are connecting to our electronic health records. We need to bring all the information into one place so that we can make smart and assisted decisions. We need to be able to enable our health professionals, our healthcare professionals, and the public in shared decision making to take advantage of the best evidence when it comes to health. And that means evidence both in terms of the science, but also in all facets of a patient's life. And then we need to be able to provide appropriate information, tools, and assistive technologies that will empower individuals to really take charge of their health care. What I've done on the next page is I've tried to lay out then what this type of connected healthcare system might look like and will begin to look like. And what I want you to notice from this is that when we talk about smart and connected health, we're talking about three very important components. We're talking about people, we're talking about technology, and we would talk about evidence-based processes here at the National Institutes of Health. Because people are the most important part of this, we're partnering with the Office of Behavioral and Social Sciences Research with their emphasis on team science to help us think through the human factor and the human component in every aspect of this kind of healthcare. So if you were to look at this model, you'll see the data pieces that many of you noticed before. You'll see something that looks like the various components of what in health we might have referred to as a SOAP note, subjective, objective assessment plan. But now bringing in these various pieces from the ecosystem around us and putting all of that into decision support. And it's that decision support, I think, that crosses over between NSF and NIH to say this is not just technology, but it's really supporting people with evidence-based process. And I think with that, Misha, I'll turn it over to you.
Next slide, please. So my name is Nsf Proposal. I'm in charge of the smart and connected health in the National Science Foundation in computer science and engineering. What drove us was was very similar to what drove the NIH that you heard from Brad, moving moving the care from episodic to being proactive, and healthcare has to be transformed, and we all know that. It has to be cheaper, has to be more effective, and will likely to rely on technology much more than previously. This slide, if you saw it, it has patient at the center, and it has to do with precision medicine and the ideal patient in the center. On the right, we have monitoring and sensing. On the left, we have intervention, and this whole process is mediated by infrastructure. And that's the view of the future care, and parts of it are implemented already. Of course, these changes require other changes such as environment, payers, employers, and so on, which we will not talk about today. If I can have the next slide, this sort of suggests that major focus in the NSF-driven part of this is on healthy people as well as patients. And in case of healthy people, we're trying to promote proactive preventive medicine and health that would avoid people getting sick. The next slide suggests several areas that are not necessarily mutually exclusive, but give you idea what kind of technological advances that need to be made in order to make progress in the transformation of the healthcare as described in prior slides. So, for example, the infrastructure has a lot of problems that need to be solved, ranging from integration of AHRs, the electronic health records, to data fusion, data harmonization, and so on. The data are not useful unless we convert them to knowledge, and that will enable decisions, and that's going to be a key component that needs to be solved. Empowering patients is a key component of future, because empowered patients are much better patients and often very much cheaper than people who are passive. And finally, all of this, in order to interconnect it, will require sensors, devices, and interfaces between bits and physics. So I can have the next slide. On the next slide, we suggest a few areas of technological and computer science kind of developments, ranging from networking and social computing to advances in control, privacy, and security. One area that I would like to emphasize, and will be emphasized again later on, is that in order to take advantage of big data at the point of care, it probably will require development of computational predictive models rather than the explanatory models that are more likely to come out of just the traditional analysis of big data. The next slide describes the objectives of Smart Health and Connected Program, and I already described them, but what I wanted to emphasize is that each project that we will consider for funding must advance the field of health and wellness to improve quality of care and perhaps reduce cost. But it also has to fill research gaps that exist that are preventing us from doing that. And those research gaps have to be in basic fundamental science development. Next slide shows how we're going to do that. So far we talked about what we're going to do. Now we're going to say a little bit about how we're going to do that. This program at NSF is supported by 3 directorates: engineering, computer science, and social behavior economic sciences. At NIH we have currently 6 ICs, 6 participating institutes, but we hope to have more in the future. Next slide, please, shows the kind of the folks that are involved in this, and I would suggest to everybody who's considering applying to actually contact one of us to make sure that the application is within the objectives of the program. The next slide shows the deadlines. There are 2 types of proposals: exploratory and integrative. The exploratory are due May 28th, and then June 3rd are due the integrative proposals. And you can find all of these on the solicitations for both NIH and NSF. I also wanted to say that this year we will have 2 rounds of solicitation. The next one will be in the fall, and that's going to be new solicitations. So just to advise, you don't need to worry about applying again in October. The next slide shows the way we review the proposals. We start by submission of proposals to NSF in traditional NSF style of the proposals. Those proposals will be reviewed by panels that will follow the NSF process, but will be joined by NIH, scientific review officers that will enable the transformation. Once these proposals are reviewed, they will be considered in a common interagency funding meeting after the scientific review officer converts these to NIH format. And those that NIH finds to be useful to be funded PIs will be contacted and will be asked to resubmit without changing any text in the format of NIH. The next slide shows the merit review criteria for NSF, and again you can find these in the solicitation. The important thing again is proposals have to have the advancement of science and fundamental advances in science, in addition to the broader impacts that are consistent with solving clinical health-related problems. Next slide. I'm going to skip this one. It has additional criteria that you will. And finally, I think I will hand it over to my colleague from NIH.
Hi, I'm David George, the Director of the Office of Scientific Review at the National Institute of Biomedical Imaging and Bioengineering at the NIH. And I'm just here to mention a little bit about how the NISF and NIH will be working together to accomplish the review. This slide here shows the review criteria across the two agencies for what's called the intellectual merit portion of the National Science Foundation review criteria and the NIH review criteria. And the important point we want to make here is that what we're very happy about is that these overlap very much so. So the NSF criteria speaks to importance, which in the in the NIH parlance is significance. Then moving on to creativity, originality, and transformativeness would fall under the category of innovation. Is the application, the work well conceived and well organized, would fall under the approach criteria. The qualifications of the proposers, how they've done work in related areas in the past, would fall under investigator. And then finally, resources, environment, and institutional support fall very nicely under the environment criteria for the NIH. Next slide, please. Then I'll move into how we're going to score the proposals using the NIH method, and then briefly mention vertebrate animals and human subjects. For those who are proposing to use them, can appropriately include them in their applications. Next slide, please. So at NIH, we use a scale of 1 to 9, where 1 is the best, 9 is the worst, 5 is ideally somewhere near the average. We score in integers. For this initiative, we'll ask the reviewers who are the NSF panelists to only score the NIH applications on broader impact. They will get the full NSF review, but the little extra bit of getting the scores for the NIH will be done only on the intellectual merit. I may have said that wrong. It won't include the broader impact. It'll just include the intellectual merit. And the next slide, please. This shows a slide that we give to the reviewers, which gives a rough correlation between the NSF and NIH. So applications that are highly competitive at NSF will generally get a score of on the order of 1 or 2 at the NIH scoring level, and that has a corresponding percentile of about 10% and an NSF text descriptor of excellent. Then moving down the competitive range, the better part of competitive will receive NIH scores of 2 to 3, again only for the intellectual merit, and they'll have a range of 10 to 20% and correspond to very good. Then moving down the lower end of competitive will receive on the order of 3s to 4s with the NIH percentiles and NSF percentiles of 20 to 30%, and those are good. And then the scores will move down from there. Again, I won't read this anymore. You'll receive this slide from Wendy, and we'll have record of it, and we can ask you, or I can answer any questions on it later on. An important part of the review for NIH is to make sure that the applicants address the use of humans and animal subjects appropriately. And if the reviewers have any concerns about the use of animals or humans, as well as the inclusion of women, minorities, and children in the study population, those can be factored into the overall impact score. And just to be clear here, this is the inclusion in a study population, not the inclusion of people who are doing the work, which is something that's factored into the NSF broader impact. Women and minorities who are actually doing the research themselves. So it's a little bit different. Then next slide, please. Here are the requirements for the protection of human subjects from research risk. So we will ask the reviewers for those applications who have human subjects to evaluate it based on these points: the risk to the subjects, adequacy of protection against risk, potential benefit, and the important knowledge to be gained. And then additionally, for those using human subjects, they'll evaluate whether women, minorities, and children are appropriately included in the study population. So in your application, you want to make mention of women, minorities, and children, whether they are included or not, and why they are included or not. And then the reviewers will evaluate that. If you're building devices or technologies that interact with children, it's certainly critically important that children be involved in the study population, just to give you an example. Then moving on to the animal subjects, there are 5 points for the animal subjects, and these need to be addressed. I won't read them all, but basically the type of animal, how the animals are being used, the numbers that should be justified. So if you say you're going to use a certain number, please make sure that you explain why it's that number, how they're going to be cared for by, from a veterinary perspective, and then procedures for analgesia, discomfort, pain, that sort of thing. And then finally, if any animals are to be euthanized, the method to be used, and if it's recommended by the American Veterinary Association. And you would just number these 1 through 5 and address each of these in your application. I believe, Michelle, the NSF has a supplemental upload at the end where applicants can address humans or animal subjects. And I think that's about it. The scientific review officers, as was pointed out, will be present at all the joint reviews, and they'll work with the panels to make sure that these aspects of the review are taken care of appropriately during the collaborative review process.
Hi, this is Teresa Cruz from the National Institute of Child Health and Human Development. For the last part of the webinar, each of the participating NIH institutes are going to talk a little bit about our specific interests in this initiative. So the mission of NICHD is to ensure that every person is born healthy and wanted, that women suffer no harmful effects from reproductive processes, and that all children have the chance to achieve their full potential for healthy and productive lives free from disease or disability, and to ensure that health, productivity, independence, and well-being of all people through optimal rehabilitation. So here I've listed the major research areas that NICHD supports. These include growth and nutrition, and here we would include breastfeeding, as well as childhood obesity, child behavior and development, maternal and fetal health, and here I'm speaking broadly from prenatal care, pregnancy, gynecologic health, fertility and infertility, and contraception, intellectual and developmental disabilities, including autism, medical rehabilitation, and here we include telerehab, assistive devices, and prosthetics and orthotics, maternal and pediatric infectious disease, pharmacology and therapeutics, pediatric critical illness and trauma, and population dynamics. With regards to smart and connected health, I think NICHD would largely be interested in topics in categories 3 and 4, where we have empowering individuals and sensors, devices, and robotics, but we are certainly open to any application that would fall within our mission. So some of the things that I would envision coming in response to this would be socioeconomic and behavioral factors that contribute to seeking prenatal care, care for chronic diseases in pediatric populations, promotion of breastfeeding, prevention of teen pregnancy, childhood obesity, participation in community-based rehab programs, mHealth, telehealth, and pediatric devices. Next slide. I just want everyone to be aware that NICHD does not have set aside funds for this initiative, so your priority score will be percentiled against the CSR base, and you are competing against the Institute pay line, which we have posted on our website. If you are looking to be funded by NICHD, please contact me. Again, this is Teresa Cruz. Prior to your application. Next slide. I'm also going to speak on behalf of Brenda Corti, who is a program officer at the National Institute of Biomedical Engineering and Biomedical Imaging and Bioengineering.
Yeah.
Sorry, Brenda. And the mission of NIBIB is to improve health by leading the development and accelerating the application of biomedical technologies. The Institute has a wide range of interests, but with respect to smart and connected health, they are looking for applications in the areas of health information, mHealth and telehealth, point-of-care devices for diagnostics and monitoring, rehabilitation engineering and robotics, and next-generation predictive models.
Hi, this is Anastasia Wise, and I'm a program director in the Division of Genomic Medicine at the National Human Genome Research Institute. At NHGRI, our strategic plan includes 5 major domains. If I can have you click the 2 of which are particularly relevant to the Smart and Connected Health announcement. Specifically, NHGRI encourages research related to genomic medicine, including but not limited to novel and innovative methods and algorithms for the aggregation and multi-scale clinical and genomic data about a patient in electronic health records and personal health records. Decision support tools to facilitate optimized patient-centered evidence-based decisions utilizing genomic data, and human-computer interfaces for clinician, patient, and family access to genomic information in electronic health records and personal health records. And I'd be happy to speak to anyone who thinks that their proposals might fall into the area of interest for NHGRI.
Thank you. This is Wendy Nelson from the Office of Behavioral and Social Science Research, and I'm going to present the interest for the National Institute of Aging from my colleague Jonathan King. And as you may know, the National Institute of Aging really leads the federal government in conducting and supporting research on aging and health in older people. So they really are looking at the range of things, but if you can think about technology and aging, technology and healthcare for the aging, all of these are areas of interest, and NIA would suggest that you contact them. Next slide, please. Brad.
Good. So I'm going to finish off for the NIH now talking about the National Cancer Institute and its very specific interest in this particular solicitation. And I'm beginning with a diagram that comes from a blueprint by the American Society of Clinical Oncology, released in November of 2011. I encourage all of you to go online and download this. And you'll see that data is the neural mechanism driving the entire oncology system of the future, and is connecting patients as well as researchers and different types of providers. So that whole notion of patient engagement, patient data, and so on is an important part for us, as well as enabling researchers to learn from this base. We go to the next. In this very same blueprint, there's a wonderful vision of what the future of oncology might look like. And if you were to think about that future, there would be a world that's especially predictive, not just in the kinds of cancer screenings that we do currently, but eventually blood assays, where we might be able to do real high-throughput computing to find out if in fact we may have some kind of molecular abnormality that could signal someone being at risk for a certain kind of cancer. If that's the case, then we'll have to be preventive. And if we're going to be preemptive and preventive, that means that we have to coordinate different pieces of the healthcare system, and that means primary care as well as specialty care. That means laboratories and so on. We have to create the right optimal displays so that anyone who is part of this virtual team would be able to make the right decision with those kinds of data. So data visualization becomes important to us. At that point, we're going to move toward a world of precision medicine. And in a world of precision medicine, then it's all about getting the right information, the right treatment to the right person at the right time. Connectivity is an important part of that. And the patient will be also a key player in this, and will be very active outside of the outpatient treatment facility, which means they're going to have in-home sensors. To prevent error, they're going to have some monitoring, and they're going to have constant communication back with the bigger virtual system. And then finally, it's going to be a participative model that we're looking at, where we need the kind of smart computer-assisted decision-making that whole groups can take advantage of, and a system where we can enable collective intelligence. If we go on to the last specific relevant criteria for NCI, do recall that if this is going to work with NCI, we need to show that this kind of basic science intervention lies on a critical path for reducing the cancer burden, no matter where that is along the continuum, whether it's prevention, early detection, coordinated treatment, or vigilant follow-up. It's also a matter of showing innovation at the intersection of both the health sciences and at network information technology. So this is a chance to really partner, and we need that kind of innovation on the partnership. We want this to be compatible with the Institute of Medicine's goal for creating a learning healthcare system. And as always, we want to balance the automation and individual group cognition components of all these decisions. So it's people working in process with technologies. And then finally, we support improved outcomes in medication adherence, healthy lifestyles, evidence testing, and network discovery. So I think that's it for all of NIH, and we're now ready to receive questions through the webinar.
Okay, so this is Wendy Nelson again. We're ready to take questions from you. So what I want you to do is you have a question and answer box on your screen. If you want to do your things that way, you can do that. You can join us on Twitter at Smart and Connected Health, hashtag Smart and Connected Health, one word. You can also email me at nilsenwj@od.nih.gov. Please don't raise your hand. Please use the question box. Again, you can join us on Twitter. You can join us in the question and answer box. And you can also join us through email. We have our first question here already. And the question is there a way for for-profit companies to participate in this announcement. And I'll let our colleague from NSF answer that.
And we do not fund directly for-profit organizations, but we do allow that organization to partner with an academic or other non-profit organization and then be a subcontract to that.
The question is, Smart and Connected Health is required to have a number of PIs. Is there a limit on the number of PIs who can apply?
For one proposal?
For one proposal. I'm assuming the question is for one proposal.
There is no limit, but there is a limit of money. So it's important that if you have a co-PI, that the co-PI does work that's important in that project. And so if a co-PI is at very low percentage, that probably doesn't show a huge participation, and the reviewers may question that. On the other hand, it's possible that people would work harder than the assigned percentage, so it's up to the proposal.
Can you please clarify the fall solicitation opportunity timeline? Yes, so you can apply in May or June, and then there will be a second submission date in the fall. From NICHD's point of view, the fall would be a preferred deadline, but I do not speak for all the institutes and certainly not for NSF.
Yeah, so these, the one comment I would like to make from the NSF's point of view is that those are two independent submissions. And the May 27th and June 3rd are the same submission cycle, and that's going to be funded from the fiscal year 2013. The October and later submission dates would be funded from the 2014 budget.
Okay, so one of our questions is, are the NIH awards the equivalent of an R21 or an R01? Financially, they may resemble that, but because of the nature of the announcement, all of these awards will be classified as R01s. The next question is, are collaborative proposals allowed, or does one have to have subcontracts to collaborators in other universities?
NSF collaborative proposals are definitely allowed.
And would be
it's
encouraged.
often a very good mechanism to develop collaborative work. And in fact, I would like to mention something I didn't have a chance to mention. One of the objectives of the program is to develop or encourage teams of multidisciplinary teams of researchers that would actually gel and work together in a seamless way.
Thank you. The next question is, will there be specific SBIR solicitations topics related to this initiative? Which organization will sponsor them?
We do not have that in plan, at least at NSF. And having said that, there might be institutes that have SBIRs in the general domain, not associated with this project, this program.
But let me go ahead and just jump in, though. The National Cancer Institute, in fact, does have one focused on health information technology, and that would be a direct tie, I think, to this.
Many of these topics would apply to the omnibus NICHD solicitation for SBIR.
So I think the point that my colleagues are making for NIH, if you have a really strong idea, you should contact your program officer at the specific institutes, because the SBIR announcement is out, and we're always looking for really good science from small businesses. So there is also a question about the October submission, but what I would do is, for everybody who has questions about the solicitation times, that is in the announcement. And instead of us rehearsing all of those announcement times, I think it might be helpful for that. So there's a question of, do we need to address the protection of human subjects in the 15-page NSF proposal limit?
Yes. I mean, there
Wait
is a-
a minute, we're having a conversation about this here.
There's a two-page
There is
addendum.
if there is a human involved in the study, you have to have an IRB preliminary, at least a letter from your IRB, and that is uploaded in a separate document, PDF. But you do not need to mention that, at least with one sentence saying that that's.
Okay, well, thank you so much for that. I just want to say, we have some questions that are very specific to people. The question that we have a question came in about MRI research. That's not going to really work in a webinar format, and I think if there's one thing you should walk away from this webinar is to know to talk to your NIH program staff about this. Some of these questions are very specific to your project, and so I would really encourage you to ask questions.
Yeah, the person asking about the radiology should definitely talk to Brenda Cordy at NIBIB.
And I'm also asking people please not to raise their hand. We are going through questions in Twitter, email, well, I'm still doing an email, as well as through the question and answer. All right. So, can I?
You don't need to slant anymore.
The question is, does Smart and Connected Health require a health organization to be part of the team? Should a health organization be a subcontract under the university primary, or is it possible to have a joint proposal?
So there's no requirement of that sort. The important thing is to have the expertise that are required to solve the problem. And since the requirement is to solve health-related problem, you need every proposal that will be considered for funding needs to have the expertise that are related to the problem that's being solved. If it's a co-PI or subcontract or whatever mechanism you wish to use, as long as you convince the reviewers that that the expertise are part of the team. I don't know if NIH has any concern about this.
My colleagues at NIH are shaking their head, which is hard to see in a webinar. There is a question that, so we're getting questions through multiple levels. Don't worry if you don't see your question, we're coming. So the question is, will there be jointly funded proposals by NIH and NSF? And what I would say to that is there is a potential for that. There is no promise, but there is always a potential. So we are working together on this, and so note that when we've gone through all the trouble to work together, there's a reason for that.
No trouble.
And then the next question is, do you expect to conduct a randomized clinical trial or feasibility studies enough?
So I can say from an NSF perspective, there's no need. In fact, NSF does not fund RCTs, and that's general policy. Now, there could be proposals that would be funded by NIH that might have RCTs. I'd like some of my colleagues from NIH to answer that one.
Yeah, the approach should be appropriate to the question you're trying to answer. So if you're at the stage where you're ready to do a randomized controlled trial, you can, but be aware that there are limitations in the amount of funding, and that may not be appropriate to complete the study. But you're encouraged to take the approach that is appropriate.
And of course, the money is relatively limited, so certainly a full-scale RCT will probably not fit within this project.
Okay, and then next question was there a training component to these proposals?
So NSF considers training as part of the broader impact, but it's not absolutely necessary as long as the broader impacts are satisfied in another way. So it's not an absolute requirement, although reviewers typically do note that either positively or negatively for the absence of training component. Now, if you have a postdoctoral fellow, you need to have a mentoring plan, but that, again, that's explicitly explained in the solicitation. Actually, the solicitation has quite detailed description of what of the training component.
We have had multiple questions about what about the institutes that are not represented on these slides or in the announcement. And NIH there are many reasons why institutes participate or not. It's not always from a lack of interest. There's many things that happen. If you are interested in submitting a proposal that might fit this, but the institute is not on here, you will need to go through NIH mechanisms. But I would suggest you contact your program officer there. If you do not know a program officer, send me an email. This is Wendy Nilsson, and I will connect you to somebody at the appropriate institute. The next question also has something to do with that. It's, should the proposal identify the specific targeted NIH institute in the proposal? Do you do cover letters at NSF?
No, we don't.
Okay, so there's no cover letters. We would hope that your proposal would be obvious to the institutes that's there. But I'm going to let my colleague.
I'd just like to remind people that these are NSF applications that are going to be reviewed at NSF. So you can certainly mention possible funders who are involved in this, but the funders, the program officers and directors from NSF and NIH work together and find the appropriate home when we can.
And I would suggest that in these situations you contact the NIH representatives and discuss this with them, because they will be the best to provide advice for you.
Okay, so there is a question about subawards, and it said, is the overhead from a subaward considered as a direct cost? It was a question of, is it yes?
Gee, I don't know actually.
Okay, so we have a question about this, and all of the
Actually,
questions will be answered and
Yeah.
posted to our websites.
My guess is that it is direct cost. The subaward absolutely will be direct cost. I would be surprised if it's not, but I'll find out, and if not, if I'm wrong about that, it will be posted in the frequently asked questions.
There's also a question, is human subjects approval needed at the time of the proposal?
So for NSF, what we require is a letter that that states that the IRB board would be willing to look at this case, and that you get preliminary information to the IRB board, but it's not required. However, I would suggest that people really consider this seriously, because at the time of award, that letter is required. And if you don't have it, I mean, the approval is required. If you do not get it, you may not be funded. And the problem this year is that the funding cycle, the decision cycle will be quite quick. So if the IRB takes months or two, you may not be able to be funded if you don't have advanced approval.
Okay. We have another question about the subcontracts, and the question is, do subcontract indirect costs count toward the overall direct costs?
Yes.
Yes, and the answer is yes. Here's another question. The question is about, there's two questions about PIs. Can we have dual PIs, which is a phenomena in the NIH system?
What does that mean, copies?
No.
No, equal, okay, so dual PIs, David, would you
So
like
then
to?
you guys have to explain that.
But that's fine, but for NIH, and NSF, they have linked proposals or collaborative proposals, that would be the equivalent.
Oh, yeah, so then
Yes.
yes.
Okay,
But they would have to be from
Explain it.
different institutions.
so if you would like to do the NIH dual, you will need to come in at NSF with two proposals that are linked in a, what's the mechanism?
It's collaborative proposals.
Collaborative proposals, so you, each PI would do a proposal with their portion of it.
Right, and then when they come into NIH, you'll designate whomever you wish to be the contact or lead PI, and then they would come in, be submitted as a single application to NIH with multiple principal investigators listed.
But I'm not sure that actually we can have collaborative proposals within the same institution. So I'm not sure about that.
Okay. So if your co-PI was in another institution, we're clear that that's
Yes.
okay.
Absolutely.
But the question is, if you're at the same institution, we will post this on the frequent,
Ask question.
ask questions. The next question had to do with, your questions are coming heavy, so we're trying to keep up here. Is this open to early career principal investigators?
Yes, and the new investigator status will apply where appropriate. If you are a new investigator to NIH, each institute treats that a little bit differently, so I would defer that to the funding institution. But if this is your first R1, you will not be a new investigator subsequent to this funded application.
All right. The question now is, does the health content of a smart and connected health proposal need to fit with an NIH agency in the smart and connected health solicitation? And I'll let my colleagues from the Institute answer.
So there needs to be an IC that's participating that your application meets their mission. But NIBIB is fairly broad in their mission, so if things don't quite fit, they would probably be assigned there.
So I think it's important to really look at the mission. We have a website at NIH. I will include that with the frequently asked questions. Talk to your program officer. That's why they're here. They really want to talk to you about this. And you need to make a case so that it's clear that it's important to them. So the question is, what was the success rate for the Smart and Connected Health? Well, it was actually Smart Health and Wellbeing last year, but what was the rate for that?
So I just want to make sure that what I say is very clearly related to the program that was purely NSF run. And we had about $15-16 million last year. The year before that, we had a couple more $million. The success rate was relatively low because we got a lot of proposals. We got 400 different proposals, 300 projects. And the larger ones, the integrative, we had a success rate of about 3%. The smaller ones, the exploratory, were about 6%.
So there's a couple of questions really talking about how do we decide whether it's an NSF proposal, whether NSF is interested in funding or NIH, or how is that decided when it's being submitted? And I'm going to let my colleagues.
So there's many different factors. We work extremely closely together. It's funding levels, it's mission. But we really do the best we can to get the high-scoring applications funded. But keep in mind, one of the benefits of applying to this is that you could have funding from either NSF or NIH. If you have an application that is very much a standard NIH Ro1 and there is a standing study section that can do a good job reviewing your application, this might not be the mechanism for you. So think about, does your idea go maybe a bit beyond what is typically reviewed at NIH, and an NSF review panel would benefit.
There's also a question about who picks the panels for review. Is it NIH or is it NSF?
So typically the NSF is in charge of picking up the reviewers, but I hope to get a lot of help from my NIH colleagues and get the reviewers that review at NIH as well. But the panels will be executed and run at NSF.
With a lot of support from NIH.
With a lot of support from NIH.
And then there was also a question whether NSF is funding any of the proposals on their own or whether they all get channeled to NIH. And be clear that both NSF has money set aside for this. NIH will be including these in their standard pay line. So you have multiple, you have opportunities here. You want to add to that?
Let me add one thing. I guess one way to think about this too from the NIH side is the whole notion about study sections that typically don't treat these kind of proposals well. So we sometimes get at NIH, we get these proposals in that are very heavy on the computational side. And now we're going to be able to give those proposals a fair shot with every one of our other proposals coming in, and they'll meet our pay line at the same time that NSF is going to be approaching their percentiles.
So there's a question about, is there a limit on the number of proposals that a co-PI can be involved in?
Yes, there is.
Limit on the number of proposals a co-PI can be in, on.
Yeah, I think that's spelled enough in this solicitation.
Okay.
If I recall, it's two principal
Yeah.
investigators. A principal investigator may submit 2 applications. I'm not sure that it speaks to co-investigators. So, but if it's a co-PI from NIH, it's equivalent to a multiple PI. Then
That's what
it would count.
I think so. I think that's the same thing at NSF.
Okay. Sorry, we've got lots of questions. So will biosensors, portable MRI development proposals be reviewed by NIH or NSF? I don't see NSF EECS participating in this program. What is an EECS? Do we know?
I mean, I think it's engineering. I'm not sure what the acronym is for.
Engineering's involved.
Yeah, engineering is involved, and if a proposal falls into engineering, we'll get our engineering colleagues to involve that, to review that.
So I have a question about the time from when you write a proposal to the award. I think it's spelled out in the solicitation, isn't it?
There's a statement of that, but if you submit in the first submission dates, we need to will be awarded the proposal. Then that must happen very soon, because the deadline for spending the money would be October 1st. So
Okay.
it would be within 3 months.
Okay,
But normally it may take up to 6 or 8 months.
good.
Sorry, the ones for the fall deadline, I wouldn't expect those to be paid by NIH until the following spring
Right, same
or summer.
at NSF.
Yeah.
There's a question here, a very interesting question. It says, what's the benefit applying to this announcement over Standard Ro1? And maybe Teresa, you'd like to answer that one?
Sure, I hinted at this a bit. So the benefit is that you have 2 agencies looking at your application for funding possibility. NSF has money put aside, but NIH does not. The other benefit is the review. So as I said before, if this is a standard Ro1, NIH, there's a study section that can cover this science, then this probably doesn't benefit you. It's a lot of hoops to go through. You're writing a different type of grant because these are going to NSF. But if you have an idea that doesn't typically do well, it might be a new area for an NIH study section, and you could benefit from the review at NSF, then this is something you should consider.
And this is David George in review. A discussion with the program director would be a very valuable component to making that evaluation.
Thank you. The question here is, should the application, please don't raise your hand, please ask questions, either email, Twitter, or email, Twitter, or on the question and answer box. The question is, should applications focus on the healthcare outcomes, or the technology, or both? And I will let all my colleagues are nodding, which is hard to see in a webinar, but responses?
Both.
So
Both for NIH.
I think we spelled it very clearly in the solicitation. We paid a lot of attention how to express that. Each proposal that is a good candidate for funding has to have both, has to address important health or medical problem, but it also has to advance science, either computer science, engineering, or social behavior science, or medical science. But it has to have both components.
And the study sections will evaluate this and debate this, the merit of the clinical significance and the application, as well as the merit of the underlying scientific background and the work needed to be done. So you want to be as strong as possible on both.
But at this point, I would like to mention something very important. Applications or projects that simply apply existing approaches, even to new problems, are not going to do well in the NSF review. What is needed are fundamental advances in the underlying science and knowledge.
I think we've had some troubles with the sound, and I will tell you that we will be posting these slides. They will be archived, they will be captioned. We will also be doing a frequently asked questions, so if you missed any of the questions, we will be putting them on the website. I have one last question, and it's a question about somebody had mentioned that computational grants may not fare well at NIH. I think that has happened sometimes, but the question is, on this call for proposal, it says if we've already been to NIH already, we can't go back. And NIH has a rule about submitting the same grant to multiple agencies. So if you have submitted this exact grant to NIH, no, you cannot submit it for NIH again. But you should be talking to your program officer, saying, what you're interested in, and is there a way that you can make this, that you can reshape your topic to make this work. Again, I think if you don't take away one message out of this, you should really know to talk to your program officers. So with that, we are at the end of our time for this. We will be posting our webinar. We will be archiving it. We will be posting it. We will have it up as soon as possible. But we will also be doing a frequently asked questions. My colleagues and I will be working on that and posting that next week. And again, please read the solicitation, talk to your program officers, and good luck on your submissions. We're very excited about this announcement, and we're really looking for some transformative science to come through. So thank you very much for your time from NIH and from NSF. Thank you.